Let's start. Hi, good morning, everyone, and thanks to all participants who have joined. Uh, though today is Saturday and holiday, most of the people they are not working. However, some of the frontline workers they are still working in the hospitals or in the field. I welcome Dr. Jugal Kishore, professor and head uh, Department of Preventive Medicine, Social Medicine, Preventive and Social Medicine at Bardhaman Medical College. And today's topic is a comprehensive management of COVID-19. And we have three topics. One is a public health approach key to control COVID-19 in India, which will be given by or deliberated by Dr. Jugal Kishore. Second topic is hospital preparedness and infection prevention control for COVID-19 will be taken up by Dr. Valan. He is from CDC India. And third topic is international and national framework for COVID-19 management. I will take it by myself. So just giving the introduction of Dr. Jugal Kishore, he does not require any formal introduction. So many of you knows him very well. He is a fellow of Indian Association of Public Health, uh, fellow of National Academy of Medical Science, International Medical Science, Indian Association of Preventive and Social Medicine, INMAS, fellow of Indian Society for Malaria and Other Communicable Diseases, and fellow of Indian Association of Adolescent Health, and fellow of Indian Academy of Social Science, and also member of 15 professional association or organization. Dr. Jugal Kishore is a medical educator and public health expert, presently working as a director, professor, and head of the Department of Community Medicine, Bardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi, which I said earlier also. And he has more than 250 research papers published in journals, in magazines, and in dailies. And he has authored 32 books. So he's a academician, public health practitioners, and also involved in so many response committees and also part of the active response of the COVID-19. We have another speaker, Dr. Valan, who is the public health specialist from CDC country office in India, and he's expert in IPC, infection prevention control strategies, and also he has worked in several national and international agencies. He has over 15 years of experience, and he will take the second topic. And I am Dr. Rajeev Sharma. I am also working with CDC. I'm working with Dr. Valan. I'm from CDC country office in India and lead for emergency preparedness and response. So we'll give before giving floor to Dr. Jugal Kishore. So what we'll take, sir, we will start with your presentation. Once you finish your presentation, then Dr. Valan will take over, and then followed by me. I will follow him. My presentation is the last presentation, and then we will take all the questions together at the end. Is it fine with you?
Yeah, good.
So I will just give control to you, sir. So please take over. Thank you.
Thank you very much, Rajiv and Valan, organizing this webinar. Actually, the purpose of this webinar was to sensitize our public health people in the country how we have to play a role and make the things comfortable for the state and district level. Are all the medical colleges, particularly Department of Community Medicine, and at the district level, we have people from the epidemiology division. So they are all working day and night for this COVID. And what strategy is going on and what better we could have done, we'll discuss today. I have made it comprehensive because the public health angle, the hospital angle, and then we have national or international, framework. So most probably within 2 hours, we are going to have very good, understanding of the COVID strategy which is going on and what we can do. If we will be able to handle some of the question, I think would be much better. Everybody is talking about COVID, So it has become necessary for us to give the right information, and people like you from the CDC, I think the information would be much better as what we have in news. So I'll start with my presentation, and I have few slides, and anybody can note down what need to be asked. Later on, we can take up the questions. So yeah, everybody can see the slides now.
Yes, sir.
Okay, fine. So I'll talk about this. What was the public health approach in this COVID-19 pandemic, and what the country is doing, and what could have been done. If we go in history, we have a very serious, or rather very threatening and rather learning history if we talk about the communicable diseases. And it start as old as, rather we have history beyond uh, the birth of even Buddha. We have some evidence that there was some pandemic in the world, but whatever reported history is showing why I have taken this plague of Justinian, which actually started in 500, and you can see that every year there were multiple occurrence of the problem in various part of the world, and then it goes on up to 590. So 100 years the people have suffered uh, deaths and suffering. You can see that it's a huge uh, burden on the whole mankind. So we have come out from that, and later on then we have another history which is again known as a Black Death, and this word quarantine has come from this Black Death. I am omitting so many other history which are there for the purpose of making it short, but just to highlight that mankind or the human race is not new to this type of pandemic. We keep facing such kind of problem, and in every such pandemic we are having similar kind of measures, or say the preventive steps, which are true today. That's very interesting one. So this quarantine which has come, like sailors were asked to stay for 14 uh, 40 days at the sea shore or sea, and when they were found negative, then only they were allowed to be part of the society and able to work. So from there this word has come, quarantino, that is 40 days. So this quarantine is nothing but keeping away from the common people, or say society. Now this is another one which is a great plague of London, and again you can see almost 40 outbreaks occur in 300 years, and huge amount of suffering, loss of economy, and death of the people occurred. And again you can see that all entertainments were banned, victims were forced shut down into their homes to prevent the spread of the disease. So these are measures which are there as old as 1656. So these are measures which are there in our society. Another one is smallpox. Everybody knows that how much death caused because of the smallpox. Fortunately we had the vaccine, and that is the era started where the vaccine can play a role in control of the diseases. And we have large number of vaccines, and we are hoping that this corona can also have the vaccine. So maybe, but what is to be learned that it requires almost 100 years to abolish smallpox, or rather more than 100 years. So it is not simple task that we have the vaccine in our hand. So we'll be able to manage the situation completely. Again, we have the diseases, and because of this cholera epidemics and outbreaks in various places, you can see that large number of people died, and whole world suffered from the cholera pandemic. And cholera still is a very very serious threat to the communities where it can occur. So from there, most of the public health measures has come out, where the epidemiology started looking into the numbers, and all statistics emerged out from a study of the you know epidemic of cholera. So now come to this pandemic, this COVID pandemic. So what is here is different from other, is that you can see that in December, uh, 27 cases of pneumonia reported. Although they say that 6 December there was one case, or in very short period time we have large number of pneumonia case and the cause was not known, and it was reported to China CDC and then WHO. So in weeks time, the things start spreading, and in just 1 week, in many part of the world we had some cases. So what is interesting here to understand, that the spread of infection in today's time is so fast that one cannot imagine that it used to occur in years together, but now it is within days or a few weeks you can have the repercussion in a corner of the world. So that is what I wanted to just highlight, that WHO just decided that it is a public health emergency of international concern, and within 2 weeks, less than 2 weeks, they have to say that I think this is something bigger problem, and on 11th March they declare it's a pandemic. So it was already in many of the continent, although it should have been done much early, but definitely it shows that you have to be very prompt nowadays to state that this disease is dangerous to the human race. You can see it's a most recent one, and again I have taken some of the data of WHO to present that how this is spreading. I think all continent, all countries, it is almost said that 213 countries have one or two cases, but most of the countries have large number of cases, and some of the countries are having hundred thousands of cases. So that is what bubbles are showing in the map, that this is now whole world is involved just within few months time. Now current situation is that we have 76 lakh cases of corona, and 4,24,000 deaths are there, and recovery is also very good, that is 38 lakhs people are recovered from this. But when we compare to India, there the cases are already crossed, like 1 lakh we have already crossed. It is almost now 1.5 lakhs, and then the deaths is quite low. We have 8,000, and recovery is also very high. So we'll discuss that why this is all. But what is appear to be that we have the incubation period of 2 to 14 days, and possibly it is 0 to 27 days. And that's the longest one. That is why we want the 28 days of the quarantine is the best one. But today we are having much lesser, days of the quarantine. A little bit of coronavirus. Just want to highlight here that we have 4 types of viruses, and the beta coronavirus is probably common in rodents and bats. And if the exposure to these animals to human being, then sometime this virus has tendency to jump to the species and can cause infection to human being. And that is older version that today we are seeing. Maybe I think it has come from bat. and then it is spread to men to men. But anyway, the corona in the population is almost 2% of the population have the coronavirus. So various kind of coronaviruses are there, and this is another projection showing there are around 8 strains are there of the corona, the present pandemic, which are circulating in the world. So minor changes occur, and this occur because of it has the genetic makeup, and that a little change of their genetic structure can lead to a new virus. And if it is substantially more, then it becomes genetic shift. Otherwise, minor variation keep occurring in time to time, or maybe country to country. That is why we have the genetic drift keep occurring, and that's true for the flu virus. And from the very beginning, we are labeling this corona similar to flu-like, but still we don't know much. We are learning about this virus. Now, why I am focusing on these all issues? Because in epidemiology, when you start talking about public health action, we must understand what are the epidemiology. That is the agent, host, environment, and where the agent comes, and the virus. We have discussed that what kind of virus it is. It spoke like this is the coronavirus. It's a very heavy virus as compared to other viruses. But the age group where it can affect is 0 to 74 or 75 years. Although the median is 47 days, 47 years or 50, around 50. Older is having high load of the virus, and residents like the nursing home, hospice, elderly homes are suffering more, because it is found that they are more susceptible. Male are more, maybe because the male are more motile, or say mobility is more in male. That is why could be the reason of the involvement of male gender as compared to the other genders. Occupation is also like the people who are dealing with the patient, they are exposed more, or those who are dealing with the human subject in the service line, they are more prone to develop the infection. So more common occur in those areas where the infected person is there, and he has come in contact with the other. So overcrowded place where the person is working. So these are all risk groups which has complicated. Another of the host factor is like if you have comorbid condition in which asthma, chronic lung disease, diabetes, and serious heart infections and diseases, and chronic kidney disease, serious obesity, immunocompromised situations, and liver disease. They are all risk factors which are making the vulnerable to the occurrence of the infection. Now, what is learned is that there are 3 types of transmission which could be there: droplets, airborne or air transmission, and then fomites. So we know now that this is mainly because of droplet, but the chances of fomites and airborne is also there in certain situation and condition. If our doctors are working in hospital, or like the ENT surgeon is there who is dealing with nasopharyngeal procedures, then the possibility of transmission is quite high. Similarly, if you have a fomite and you are cleaning the surfaces, I think you have more chances. So there are, but the possibility of fomite transmission is much less as compared to the droplets. So droplet is the one which is the main cause of transmission today, according to the available literature. Now, this is a little bit of understanding that what are the factors which help the droplet to be remain transmitting this infection. So it requires temperature, humidity, and then size of the droplets. How much size of the droplet? If it is small, it can remain there in the air for a longer period. If it is high, then it will fall on the surface, or it fall on the place where directly it can go to your respiratory tract, and overcrowded place. So these are the important factors which helps the transmission of this virus. Another one is learning of that. If it's aerosol, then how much time is there in the air? If it falls on the plastic or stainless steel or a copper or cardboard, how much time is there, where the virus can survive, and if it is, touched or maybe, go to your respiratory or oral cavity, then definitely start multiplying. So these are the times it shows that nothing to worry if you know that which surface or place, how many times and how you have to handle these all surfaces. I think it become easy, but definitely the nosocomial transmission is very important source of infection in healthcare worker. And in India we have the evidence of almost, I think, more than 50 and other groups, doctors, nurse, in other, I think almost 100 people are died. And how many number of patient would be positive? We don't have data of that kind, that how many are actually positive in our healthcare setting. And it is because that we are having close contact with the patient, and this understanding or this knowledge is affecting both way. It is affecting us, be afraid of while we are dealing with the patient, and at the same time it is forcing us to have very good hospital infection control. So Valan is going to talk about this, that how and why we have to do this all. Next is we have the transmission by the stool also. Although we don't have any evidence, but in stool, we have found the virus presence, and also in sewage system, the virus is also found. It is also found in one case has been reported in a vertical transmission. Although till now we were finding that vertical transmission is not there, but one report has been showing that could be there is a possibility of vertical transmission. So wherever the secretion of the body fluid is there, there is a possibility of, although we don't have evidence of the urine and other that it can transmit the infection, but we require more research on these issues. But what we have found out that yes, our domestic, cat and tiger has found positive with the COVID-19. So we don't have a reverse, like it is because of human infection which is transmitting to these pet animals, but we don't have that otherwise, like from them we are getting the infection. So again we require more research on this. So this is also important, that we have to take care of the animals when they are part of our home, that they should not get infection, and they may also develop problem if you are positive. So keep the animals away also at the same time. This slide is also indicative only. It's a diagrammatically telling you that when the virus load and antibodies load is there in the body. So what it is found that 2-3 days or maybe maximum of 1 week before the occurrence of a sign symptom, the virus is starts shedding, and in that is why it is known as asymptomatic patient can shed the virus, or pre-symptomatic. Study also shown that those people who are shedding the virus and they are asymptomatic later on become symptomatic, so they are known as asymptomatic. And then after symptoms, it is found that up to 1 week virus load is quite high, and it keeps transmitting the infection. But after the 1 week, it is rarely found. So this is also important for everybody to understand that this kind of patient who is shedding the virus is not continuously shedding throughout his recovery and other. You can see that IgG level and IgM level raise after the 1 week, and then it continue. So IgM level decreases, but IgG continue for even many weeks, or we have to see that how many months we can have the IgG. So that cohort is going on, and natural history of disease are coming up, and we are learning about this virus more and more. So we have asymptomatic, pre-symptomatic and symptomatic transmissions. So and all the three stages we can have this sampling, and we can find the positivity. We have the gold standard test, that is the RT-PCR, real-time PCR, and the positivity or say the sensitivity and specificity, it varies. Like specificity of this test is quite high. That is why it is a diagnostic test, but it cannot be taken as a screening tool because the the sensitivity of this test is not very good. But anyway, we have only this test, and the antibodies test are still in experimental phase, and some of the test has been recognized by the ICMR to be tested, and zero surveillance is already done in some of the state at the country level, and they have found some findings. So what is to be understood that all three way the transmission is possible. Now here just a little concept of R naught, that is the basic reproductive number. One patient, how many he will develop, he will transmit the infection to others. So if this value, this R naught value is more than 1, so you can see that it is infecting more than one person. If it is 3, means 3 person will be infected from one person. If it is less than 1, then they decrease infection, like it is not going to infect. So that is why it need to be calculated, although there are conditions for which this R naught has to be calculated, and there are like no one has to be vaccinated, no one has the disease before, and there no control or spread of the, no way to control the spread. In those cases this R naught play a role, but still it gives a very good idea of how much infectivity of this. So we have the susceptible person, the infected person will transmit the infection to susceptible person, and then it spread to another. So that become 1. But if we have like 2, then 2 person get infected. So you can see that how it exponentially increase. So that is more infected the virus is, the more chances of transmitting infection. So if in the beginning we were learning that this corona is having more than 5, R naught is more than 5 or 6, so it is spreading very fast. But today we know that this is not exactly 5 or 6, but lesser than that. In India it is coming out to be 2.3 or less than 3. So that is the spread of infection in the community. So what is here, that how we have to calculate the R naught. So there the infectious period, contact rate, and transmission. So this is also important for public health action, that if the contact to the infected person is quite high, then the chances of infection is more. If the risk of transmission per contact is quite high, like the virus is infectious, then the possibility of getting infection is quite high. And if the infectious period, like in this case, we have found that occurrence of symptoms, before occurrence of symptoms, we have 1 to 3 days. And after that, almost 5 days. So we have a, period of almost, I think, 8 days where the person can infect. So if it is increasing or increased, then the chances of infection increases much. If it is less, then the chances of infection is to other person is less. So these are all important things, that how many time, how much dose you are getting, and dose depends on the contact and the transmission per contact, how much viruses you got it. So asymptomatic will shed less virus, so it is going to have less effect on transmission or maybe the infection. So that is what we learned from this all calculations. So in public health, these all important things are there. That is why we don't want people to have the contacts. If you decrease the contact, the R naught will be less. If we can decrease the load by whatever methods, by hand wash or by your cleaning and everything, so transmission become less. So you are shedding the virus and you are cleaning the virus much faster. So I think the transmission become less. In infection, we know that we have sign and symptoms, and everybody understands that if you have a fever, chest pain, chills, rapid heartbeat, breathing difficulty, pneumonia can occur, and then other organ start deteriorating, and you have a problem. And it is found that majority of the time it is a mild infection, but 5% will have the moderate, and then less than 1% or 2% we have the critical cases. So that is the understanding today we have. And understanding of this is giving that, why we should not worry much about it. It is majority of the time will be mild and can be managed. So we should not have a panic. What the panic we have today should not be there in the community. This is the study done in China, which shows that what kind of age and the gender and then history of exposure, smoking history, comorbid condition. So in survivor and non-survivor. So these are, early studies which are giving some idea that who is more prone as compared to others. So we have all like, will they develop the sputum or mileage or maybe fatigue, diarrhea can be there, or say, some of the scores or heartbeat, blood pressure. These are all, compare with the survivor, non-survivor. So they are giving some understanding. Now we have many more studies to find out what is the difference and what are the clinical presentation of these cases. The next part is that you have the sign symptom, then diagnosis is very important. Now, because of it is infectivity, we have to have, a separation of patient and whoever is, getting the, the swab. Nasopharyngeal swab create in you is gag, and then you just try to cough. So if you are not having the shield on your face, I think all droplet will come on your face. So therefore, some such kind of indigenous methods of separating, things were created, which were not there before. So these are all inventions later on, just because of the situation created by this COVID pandemic. And then we have the, RT-PCR, and later on we find that not every place we have the RT-PCR because it's required the, sophisticated lab, and the safety measures in that lab is quite require high. So BSL 2, more than 2 would be better, but if 2 is there, still we can use it. So initially, we were there in the whole planning, and we were finding that at the national level, not many PCR were working, but they were working in a research. So they are all converted into, some kind of a COVID testing. And then we have the CB0, which is, doing the testing for the TB patient. So they were also used for this. So now this whole process was to increase the testing, facility at the national level. Remember that if we cannot test, it is difficult to find out who is infecting the people. That is why the testing become important, and more testing is required, so we can identify and we can separate them from rest of the population. And that is why the concept of isolation and quarantine comes. So the public health measures are such based on the natural history of disease, how the virus is behaving. Unfortunately, we don't have treatment for it, no vaccine and no specific treatment. So whatever we are giving is symptomatic supportive treatment, and it should start as fast as possible. Still, using with the supportive treatment, the death rate decrease manifold. So that is also very important. Now we have the secondary infection should not develop, so we have antibiotic. If respiratory distress is there, then we have oxygen, or we have the ventilator. So these are all important things. Beside that, we learn more about that what are the things happen in the body. So to control that, all these measures has been identified, and we are doing it. So these interferons and chloroquine, hydroxychloroquine, I think everybody understand that why this was started. At least some kind of a prophylaxis if we can give. So we already have evidence before that such kind of infection can have benefit. That is why this hydroxychloroquine has been used, and some effect was found in if it is given in prophylaxis, and particularly in health workers. So later on we found a little benefit also. Similarly, we have antibiotic like the azithromycin, And plasma therapy is the one where, patient who has recovered had developed the antibodies against it. So these antibodies can be separated out and can be given to the patient who are suffering from. So this is another method started. So we have many multiple, remedies, multiple strategies to, have the clinical problem under control, or treatment modality can give some kind of relief to the patient. Now I'll focus now on what are the preventive and control strategies we have developed. So what should have been, and it has been in India, that immediately Epidemic Disease Act should have been started. If we WHO identify that this is the pandemic or epidemic, immediately Epidemic Disease Act should activate. Unfortunately, in India, we don't have the Public Health Act, although we have the Disaster Management Act, which have the power to control such kind of eventualities and calamities. But Public Health Act should be in place, which should be comprehensive in nature. But the Disease Epidemic Act, which is very old, but it is now appealed, and it was amended and made suitable for the COVID, and it is now working in the country. So this gives the power to health department, so they can exercise what is required for preventive measures. It's a very, very, very important. Otherwise, the administration or say the people will not behave in the manner what the health department wants. Now, in the beginning, the best method is that you have a country which has a border and the infection is somewhere else. So people coming to your country, if you limit those people, if they are not coming to your country, definitely, the infection will not come to you. That is why international ban or international, travel was banned, or say, at all airport and port, the screening tests were used. But unfortunately, we didn't have very good tests. Only we used to measure only temperature. But that was only just one method by which we can find out somebody has the fever. So we can identify and we can separate and do the testing. So this is one of the best method of controlling your own country. So you limit that one. Next one is, if they have come inside, or, in the, wherever the case has occurred, you try to, just pick up that person, and then, all the people who are come in contact with that become a contact tracing. So you separate that person who is having sign symptom, that become isolation, and those people who are in contact become a contact tracing, and those who are having the sign symptom, they will also be isolated, or they are tested. If they are positive, they can be quarantined or isolated. So that is a good method of saving the larger population from a few people who have come from abroad who are infected. So that is what the contact tracing and surveillance is, the process by which you go house to house and try to find out whether the person is having any sign and symptom similar to COVID or similar to that infection, and then catch that person, and then you separate from others. So that's the method of age-old method of controlling the outbreak. So that is the very important preventive and control measures strategy in public health. Next is a risk communication. In India, unfortunately, we don't have a specialist of the risk communication, and that is the most critical. And that is what happened in country in India, that we have so many people talking so many things, and ultimately the people are confused. They don't know what to do. And I have been going to media like in TV and DD News and other the Lok Sabha news, and every time I'm finding that the people are asking same question again and again and again. Why this is happening? Because they are confused. They are not understanding what is, and panic is there. In panic, even the correct information you will not believe. There is a doubt. So this risk communication, I want that India should develop very good risk communication. There should be a data managers. There should be, risk, the communication specialist dedicated to the population, which are we should deliver, what information should go to the public. Then only I think we can have better control of this pandemic, which is still not happening. Next is the community involvement. Now, I have gone in 2-3 states and learned from the rapid response team and then interministerial, team. What I have learned that unfortunately our all system, whether it's a, medical or the administration, the involvement of community is not there. And that is one of the very important preventive and control strategy in pandemic, because the community is suffering. They are one of the most important stakeholders. If you are not involving them, I think you cannot be successful. Wherever they have been involved, I think the results are good. Because, take an example of, suppose we take the ASHA worker, they are part of the community. Are they fully aware of what need to be done? Are they given power to do certain things? Or they are only just, going to house and getting some kind of information? Or, you have the leaders in the village and also in community like Delhi, we have the RWAs and, these all peoples are there. Every place we have been just forcing them to do certain things without, involving them. That is what I wanted to say when we say about community involvement. I think this is the most crucial and important one. If we can start today also, we can have good results. Next is the international comparison. Although this is only possible when we have, good data. If we don't have good data, then comparison between different countries is not possible. But whatever data we have, we are making some comparison, and we are knowing which country is doing what. And we are also learning that what preventive measures are there, they have done, they have adopted. So we can follow the similar kind of thing. Like, for example, we take an example of Kerala, which has done good. So the similar, we can compare within the country, within states, such new practices or innovative practices. And sometimes we have used the word model, so Jaipur model or Jodhpur model or Kerala model or this model. So that is what is started. But whatever it is saying that, some kind of comparison is required in different strategy, because may not be all strategy will work, or some particular strategy will work in your area. So you become, susceptible to all those strategy and develop a strategy for you, because India is so diverse. So one strategy may not be useful throughout. So in different places, people should be understanding that, one dictate from center or from a state is not going to be useful in all the district and other thing. So we require, understanding of the local situation and, develop that strategy. That is what I wanted to highlight here. Here we have a dry system. This is again very important in disaster, calamity or pandemic, because the public health does not have huge resources. Resources are always limited. So we have to utilize the resources in a very, very effective, efficient manner. So, the resource should not be wasted. If you remember, we didn't have the kits, with diagnostic kits. We didn't have the PPE. We don't have, trained manpower. These all things were not there. So it is only possible we are doing this trials so we can utilize those or, effectively. And then we have to change some strategy and policies also to make things more comfortable. Accordingly, then we make the isolation. And then what I found is next is the quality of care. I think infection control, biomedical waste, Dr. Valan is going to, discuss a little bit more. But this is another one of the important, component of preventive strategy, or say the public health strategy. If our quality of care is not good, I think the whole structure will disorder, or maybe I think people will not have faith on whether it is a private or a government or whatever. We have to focus on quality of care, which is lacking in most of the places, and I am keep telling that, please focus on quality of care. The patient should be satisfied. Patient should get what they want, and at the same time, you have to see. So all the management, hospital management and, healthcare system has to be very, very susceptible, or say the sensitive to the need of the people, which is unfortunately not happening. Handling of dead body is another issue. So if we see all these things, I think nowadays in Delhi, it is happening that dead bodies are not handled properly. You can imagine that, dead bodies are a very sensitive issue to any community. And if they are not being handled properly, then I think the trust between providers and, the patients, or say the community, lost. And you cannot gain that one. And then all the community involvement and participation of all kinds disturbed. So you can imagine that everything is linked to each other. So I have focused more on this slide just particularly because it have all the strategies written, which have, one relation with other, and very importantly, related to one another. Another thing which I have noticed in throughout my experience of this COVID pandemic is the provision of mental health, counseling and stress management, which is almost not there. The stigma is again so high, and it is, dictated by our administration that don't do this and that, and they were penalized also. But somewhere we are not able to decrease that stigma. We are not able to decrease the stress among the family member or a patient or health workers. We don't have any program where health, mental health can be provided. And this is very crucial. So you can imagine that all these are very important, but somewhere very important component of whole strategy, comprehensive strategy, is lacking somewhere. As far as the risk communication is involved, is concerned, or the community involvement, or quality of care, or mental health care. If we are not providing these all things, I think we are missing the whole game. If I have time, I think that yes, quarantine facility were established, and then you can see that it's all initial phase of the preparedness. Later on, these kind of figures stop coming, but in the beginning it was there. Surveillance strategy, already know that how frequently we are changing, and even doctors are not aware of that, whether we have to isolate the person for 7 days or 10 days or 14 days, because this keep changing. So 14 days initially it was kept, but because of the lack of resources, then we have reduced it. Then we have divided the whole thing into color, like we have orange and red and green zone, and then containment area. And then we have 3 kilometer and 5 kilometer buffer area. It was meant for the rural areas, but in urban areas we didn't have that much understanding how you have to contain it. So those policy, or say the strategy, was adopted, that how you have to do this containment in urban areas and locality like Delhi. Then these are the risk communication. I think again I have to emphasize that not only just the community, but the government authority, different authorities are there, so they should be aware of. Just issuing the guidelines are not going to serve the purpose. We have influential people, they should be aware of what kind of communication is required to them. We have a travel tourist and this press reporters, their press release should be done in a very, very timely and frequent manner. Then animal health officials, NGOs, they are all to be involved in the risk communication. Yes, helpline number everybody knows. Many times you'll find that it's not working. Arogya Setu is very good app, but this is successful when people are feeding the data. If they are not feeding the data, I think it is not going to be useful. And once it's there, then it does not mean that you are going to get the infection nearby. It just gives you some idea that people are around you may be infected, and you should be careful about it. But this is the monitoring quarantine. This is already known. Everybody understand that why we have to decrease the close contact, why we have to wash hand again and again, and not necessarily used to have the sanitizer, but soap and water is good enough. This is sufficient literature available now that the water and soap is good enough. Then avoiding the contact with the wild animals and other animals. Respiratory etiquettes, which is very, very poor in this country. There, community participation and community involvement is required. Unfortunately, cough and respiratory etiquettes in this country, I don't know when it is going to be developed, is again a very important component of our comprehensive strategy of the public health. Then other things like the health facilities, and this concept of social distancing coming again and again. I just want to say that this was meant for non-pharmacological infection prevention control. Now we have capacity in any state or any district or maybe any city. We have the capacity to handle the cases based on the number of beds and infrastructure we have. And beyond that, we cannot stretch. So if the number of cases, increase, then definitely we may be, collapsed. So that is what, this epidemic curve shows. If we have an epidemic, then definitely you have large number of people where that capacity cannot handle, and then there are more chances of death. So that is what, we decided that why not we, stop that transmission by forceful or by, lockdown. So that was the purpose of lockdown, that you just delay this, and that is my flattening of curve by delaying the transmission. So you have time to, make preparation, and at the same time you see that, you are able to manage it with whatever capacity you have by further increasing it or strengthening it. So that is what social distancing, help to do here. But unfortunately, what happened, the method by which we have used in social distancing or physical distancing were very crude in nature, and that is why people were so much not happy with the kind of social distancing has been done. And this kind of distancing, like the cruel method, never used in throughout the world. Only a few countries are using it. Beating the policeman, beating the citizens is not there. Anyway, we have legislations, and the IPC is also there, where we can use these all legislations for better management of our health system, and getting power to do changes in whatever problem we have or bottlenecks we have. Now, this is another example. I don't know, I should have shown you or not, but what we are showing here is the lockdown effect. Although world over they are saying that there is a effect of lockdown, but in Spain and Germany, or rather Italy, we have some effect of the lockdown. But as far as the India is concerned, that slow increase was there. So you can say that maybe I think that peak could have been much faster if lockdown would have not been there. But definitely there was hardly any effect seen. Rather, after unlockdown, the number of cases has increased. That is also indication that yes, might be the lockdown as a play some role. Now this Triads, which I have already discussed, according to Triads, the 3 level of facility has been created in India. We have the COVID care centers, then we have dedicated COVID health centers, and the dedicated COVID hospital. So accordingly, the facility were divided, and this Triads has to be done at all level. But what has been learned that not all the state, all the places, it is done very effectively or efficiently. And that is why many places we had a problem. Otherwise, this is the best, one of the best method by which we can utilize our resources. Similarly, the duty management of health professional has been, categorized like category A, B, C, and there are core departments, that clinical specialties, and other like medical specialty. Like in medical college, we have the anatomy, physiology, biochemistry department. So there, the resident can also be used. Even we thought of using our junior resident and also a student. So these plans were made initially, but unfortunately, because of the stigma, fear, panic, all were disturbed. In many places it's worked, but in other places it's totally collapsed, and but in the end, what I just want to, end up by a few slides saying that world over, we are seeing that, now the curve is, flattening, you know, for a long period now it is stable. But what is important here is Southeast Asia region, where it's continuously increasing in number. So that number will continue, but world over, if we take world as a whole, then definitely the peak is not there now. And this is all confirmed cases. So May 31st onward, now March 31st onward, you can see in mid of the March onward, we have this, continuous number of, confirmed cases, and that is not increasing in absolute number will definitely increase, but per day wise, it's not increasing. And these are the deaths. So you can see that increase was there in middle of the March, but after that, continuously it is going down. So absolute number will increase, but per day or say per, you will not you're seeing that decrease is there. So this is a good sign of this pandemic, that we are now having less and less number of deaths in future. This is another picture which are showing our new cases and new recovery. And last few days, even the government of India also said that our recovery is more as compared to our new cases. So more recovery means we have more chances of decreasing our new cases. And the time will come when we are, going to overcome this epidemic. Now, this is one study done by Anil Kumar and Rupali Roy, and that is a mathematical modeling. It shows that how this data from the world meter, they've used and shown that when it is going to decrease. So you can see that the Bally method model relative removal rate. So if the removal from the community is same as the occurrence of new cases, so it is going to cancel each other, and the time will come when it is going to start falling. So they have predicted that maybe I think middle of September we are going to have that situation, and then the epidemic will fall. So that is a mathematical model which I found is going very nicely and similar to what the world pictures are showing. So India is going to have peak I think this month or maybe next month few cases, and then going to have a comfortable position. But what is important here is that we have to look into the diseases and problems at the same time. We can't keep locking our population and things, and even hospital level, because large number of health services require dealing with other diseases, like we have the TB, HIV, and all diseases which are common in the population, which are killing also. It is not that only COVID is killing, but we have the heart attacks, strokes, and the kidney failures. They are also killing. So we have to gear up our system at the same time, otherwise the people will die from them. Or say, take an example of, if suppose we have huge number of children which are not immunized, even measles is more infectious and killing as compared to the COVID. So one should be aware of, and the polio is eradicated in India, but not in the world. So if we just or say not immunizing our children, polio may come back, and our whole 15-20 years of efforts of decreasing the polio from India will lost. So the future strategy should be that we should bring back again. So that is what public health strategy is, that it does not focus only on one aspect, but a comprehensive manner. And that is why COVID has to be dealt in a comprehensive manner, looking into the whole health aspect and society aspect. Then only I think we can manage this. So that is what I wanted to say. So suffering is continue, but definitely will be definitely going to decrease it in coming time if our community is with us. So thank you very much. And any question you are note down, and we definitely will take up. Rajeev. Rajeev is not there. Valan.
So no, I can start, sir. I can start.
Yes.
So yeah. So Rajeev, shall I start? Considering the time.
Yeah.
Okay. Thank you, Jugal sir. It was a wonderful presentation, a very good refresher after we attended the TOT from the ministry, and very nicely you explained about the epidemiology, the prevention and containment strategies we have to use, and what is working well and what is not working well, which has to be improved. Thank you so much. So let me move on to the presentation on infection prevention control and hospital preparedness. So this presentation is mainly based on the Ministry of Health and Family Welfare's TOT conducted on 6th and 7th March in Delhi. And subsequently, a slide set was developed by All India Institute of Medical Science as part of their infection prevention control capacity building activity along with CDC India office. So I am presenting those slides only. So what should be the goal of hospital preparedness for COVID? I would like to quote this from the Center for Health Security. Every hospital, in collaboration with other hospital, should, just a minute. Every hospital, in collaboration with other hospitals and public health agencies, will be able to provide appropriate care for COVID-19 patients requiring hospitalization while maintaining other essential medical services in the community, both during and after pandemic. So this definition recognizes that what constitutes appropriate care and criteria for hospital admission may well change during the pandemic. Sir Jugal sir was mentioning, initially we adapted a lot of different strategies. Now some things we found out that can be implemented, and later we realized few things cannot be implemented. So the strategies for hospital admissions, quarantining patients, isolation of cases, home isolation, all these strategies evolved because there is a huge surge in number of cases. So what is our primary objective by implementing hospital preparedness trainings and infection prevention control activities? So it is mainly to limit nosocomial spread, to protect the healthcare workers, and thus we can maintain a hospital workforce. Prevent the hospital from being a disease amplifier. Otherwise, hospital will be serving. In many countries, we have seen the hospital served as the amplifiers for the disease transmission, and not only healthcare workers, it also amplified disease from one patient to other patient. We also had seen many hospitals in India were also shut down during the initial period because there was a potential threat that they can act as a disease amplifier. So IPCs are very, very important. And also we can protect the non-COVID patients from infection so as to maintain the ability to provide essential non-COVID health care. So sir was mentioning, Indian Pediatric Association was mentioning about the decline in vaccine, which is also very, very important. The TB detection and treatment has gone down drastically. So all these are important. So all the other essential services also has to be maintained. So by implementing appropriate infection prevention control, we will be able to do that. So we all know already, I don't want to go into detail. We know how does it spread. Currently it is believed to be a droplet infection, and it will be spreading while you direct droplet infection or by touching the fomate. So by touching the surface, and then you touch your nose or eyes or your mouth, then it can you can contract the infection. So currently, the classic symptoms, we all know that it is fever, cough, and shortness of breath. And there are new symptoms also added by CDC. Those are chills, repeated shaking with chills, muscle pain, headache, sore throat, new loss of taste or smell. So this is only for the mild disease patients, and for the severe illness, you can also have, like sir has very in detail mentioned about all the cardiac issues, the pneumonias, the sepsis shock, and also. So for the mild cases, which any of the health facility can encounter, are these symptoms. So not only fever, cough, shortness of breath, but also this other symptoms also has to be kept in back of mind, because they may present with other symptoms also. So we already discussed about this, like most of the people will be asymptomatic or mildly symptomatic, and there may be a minimal population which might require like O2 therapy and admission in a hospital, and around 5% may require a critical care, or maybe even less. In India, we are seeing very less number, less than 5% people requiring like admission in a critical care unit with ventilator support and things like that. So mainly, whatever the case may be, our focus should be isolation to contain and mitigate virus transmission. So it can be adapted, like if they are like mildly symptomatic, many states have now taken a decision to home isolate and follow appropriate infection prevention control measures, including cough hygiene and masking and all those things. So that has to be, but isolation is a must. Like when you identify a case, isolation from other family members and from other patients whenever if he is in the hospital, that is a must. So sir mentioned about like 3 different set of hospitals, about like COVID care centers, designated COVID health centers, and COVID hospitals. Like why this geographically cohorting these patients are important, like you know very well, it is to limit number of health personnel exposed and conserve the supply. So also, like it will be very easy. You designate a COVID hospital, and you can mobilize the human resources for maintaining all the severely ill and like critically ill patients there. So, but there are barriers also for this geographically cohorting, because there is a huge surge of cases. Most of the hospitals, these COVID hospitals, have reached full capacity. And like the location of like some places, like we are hearing that the location of the isolation rooms or wards are like very far away from the city, and it is difficult to transport the patients. Like all the not in many states, but few states have reported this. So these may be some of the barriers to implement a method of cohorting these cases, like who should go to a COVID center, COVID care center, who should go to a COVID health center, and who should go to a COVID hospital. So there might be few barriers, because we are seeing surge in cases in many of the cities, like mainly in the urban areas. So what all are the potential solutions to cohorting? So what other hospitals can do is like converting single rooms to double occupancy and maintaining a distance between 2 beds, like at least 1 meter. So converting less used rooms, like many hospitals might have a pay room, like even in government hospitals, in many states, they have a pay wards and all. So these can be readily converted, which will be away from the routine care. So they can be converted to pay rooms. And like it has been already done in many states, but if not done, like as an epidemiologist supporting the district health authorities, you can recommend this. So again, you can expedite discharges for like the cases admitted with other illness, like non-COVID illnesses. You can slow the admission rate. That's what is happening in most of the hospitals. And temporary structures for less ill patients can be built. So already we are aware of like many temporary structures, like stadiums converted to hospitals, and also some railway coaches converted to isolation coaches and all. Like all those temporary structures are like already made by Government of India. And you can also convert the spaces like lobbies, post-operative care units, and waiting rooms. So this has been done in many countries, because there is more and more cases getting reported. The recovery rate is very high, but still like more, when you have more and more cases, you may have to adapt like some of the strategies based on like what is applicable to your health facility. So coming to the IPC triage and isolation. So mainly why we are like prioritizing triage is like mainly to identify and isolate. So like the triage should focus on early communicate this information to the local public health authorities, so that like they can take appropriate action and all. So any health facility, whether it is a government or private, like any health facility should have a triage mechanism, so that they can identify all the suspected cases and immediately they can separate. So like this is a picture from WHO PAHO office. So you can see here, like anybody who entering into any health facility, whether a nursing home or a PHC or a CHC, anywhere, there should be a place for hand wash before they enter. So if, after that, like they enter to the health facility. So then immediately after entering, like there should be a waiting, like they should be screened for symptoms. The common symptoms, we all know that fever, cough, and the shortness of breath or breathlessness. So if they are there, they have to be immediately separated to a separate waiting area. And all the time while waiting to come into the health facility or entering and waiting in the waiting area for clinical examination, every time at least 1 meter distance should be maintained. So because like, see, minimum is 1 meter, but if you can maintain a 2 meter distance, that is more than that is more better, because droplets can still travel to like up to 8 feet. Like when you strongly cough. And also again, one more important thing is anyone who enters, like already Government of India has given masking for all the general public when they enter into any crowded area, but anyone entering into a health facility should not enter without a mask. And if you feel like the mask is very dirty or like something like that, please issue a new mask in the healthcare facility. So like from the healthcare facility, you can give to any cough symptomatic a new mask, so that you can prevent the risk of that person coughing through the mask and transmitting the infection to others. So this is an example of separate triage area, like a makeshift triage area created for patient. After triage, the patients are made to sit and wait. So wherever they are sitting also, like you have to maintain social, like physical distancing between each patient, whether they are symptomatic or they are not symptomatic with respiratory symptoms. Both these patients in the waiting area, they have to be separated physically. And like already this has been implemented in many hospitals, but this should be a standard of care in any health facility now. So this is again how you can triage the patient. This picture explains about so outside the hospital, you make a makeshift tent or something. You screen the patients for cough symptomatic and maintain always 1 meter distance. So if they are symptomatic, send to a separate triage area for further screening. If they are non-symptomatic, again, they have to maintain 1 meter distance and sent to the emergency department or casualty for care. So if you are doing that, again, you are filtering at multiple levels. And if there are any suspects, immediately you can take appropriate action based on the local guidelines, whether they have to be sent to, first they have to be screened, and then public health authorities can take appropriate action, whether to send to a COVID care center or a designated COVID health facility or a COVID hospital, like based on what symptoms they are. So these are some of the examples which based on the Government of India guidelines, this has been implemented in some of the PHCs. So this is an example, like NACO, really we have to appreciate NACO program. Like they very early recognized the importance of this immunocompromised patients, like they are more prone for COVID, and like in March month itself, they decided to give multi-month dispensation of drugs. Thanks to ITech for providing all those trainings with support from CDC also, like and all these ART centers which are dispensing, they have implemented this since third week of March itself. And this is now the patient load has come down because these patients need not come, their drugs are being supplied to their homes by the healthcare workers. So like by then they have, by this they have limited a lot of people like unnecessarily coming to the health facilities and crowding the facilities and being an amplifier for the disease transmission. So for preparing for signage is posted in the entrance to direct patients, like in the local language, where they should go, where they should wait and all those things. And they should ensure like face masks, as I told you, and the registration desk, like everybody who's entering into like from the gate, from the road itself, unless they are masked, like they should not enter, and you have to give a mask before they enter into the hospital compound. And all patients, like respiratory patients, it's better to give a new mask because we don't know how long they have been wearing, whether the mask has been wet or not. So it is always better, so that still you can, if they cough also, the chances of transmission is very, very less. If masks are not available, you can request the patient to cover the face with the clothing during the entire triage process. So again, when they enter to the registration desk inside the hospital, So already sir has told about some barrier protections and all, like plastic things which was implemented for the COVID risks in Kerala. Sir showed some photographs. So again, like you either a plastic sheet or a glass barrier should be there while registering any patient, like whether like if with any symptoms they come, but there should be a barrier protection between the patient and the registration person, so that even if they cough, like they are not exposed directly. And like it's all, if by doing this, if they are in a closed space and there is a barrier protection, we can have minimal personal protective equipments for the registration staff, and you can save a lot of PPEs. Like that is one of the main thing. Like always, it is recommended to have a barrier protection, and also it is more protective. You know, you have a barrier so that they will not acquire the infection easily. And you have to identify isolation rooms if you find they are symptomatic, and if isolation separate rooms are not available, you can consider well ventilated wards to keep the suspected COVID patients. So these are some of the visual alerts for the patients. These can be put in the in hospital as a notice, like when near the gate, and also they register all those places. If they miss at the gate also, if they have symptoms, immediately they will report to the concerned person, and you can segregate the symptomatics from the asymptomatic patient, so that they don't serve as a transmission risk for other persons. So this is an example of a crowded OPD. Like we all know, like most of the hospitals, like before COVID, it used to be like this. So you can see the second picture where there is a barrier protection and visual prevention. This is not a perfect one, but still, like this type of barrier protection will help minimize the risk. So protecting healthcare workers at triage. So all healthcare workers performing triage activities should adhere to standard precautions at all time. So they should have convenient access to hand hygiene products, which is available in almost all the institutions. And healthcare workers conducting preliminary screening that does not require patient contact. Like if you are not examining the patient, just you are interviewing, or you are just asking, they have to maintain at least 1 meter distance, not unnecessarily go near to the patient, and they can ask these questions, so that like they can have minimal PPE, like just a mask is enough, and a mask and a face shield is enough if they are doing that. So if you are really examining the patient, and then like you may have to consider additional PPE, like a triple layer mask, a must, and a face shield, a must, like all those things. So if you are keeping a distance, like still mask is enough for the healthcare provider. So this is if any of the places, like for example in a casualty, if you are sitting in a casualty and there is a chance of aerosol generating procedure, like your emergency case may come, and you may intubate or like something, then they may have to wear appropriate PPE. All the staff in the casualty should be wearing respirators and face shields and everything all the time. So it depends upon like what kind of patients you are expecting. You may have to design your personal protective equipment. So while performing triage, the patient presenting for care should screen for signs and symptoms of respiratory infection and potential COVID-19 exposures at the triage station. The question asked during triage may vary depending on COVID situation now, because earlier we were focusing in the March month, we were focusing on more of international travel and things like that. Now, when more and more local cases are also there there are many hotspots identified in many of the urban areas. We may have to ask the questions related to whether they are coming from a containment zone or not, whether they are coming from a red zone or not. All those questions as this is evolving, and based on that you may have to ask the question, and then you may have to segregate these patients. If the triage should be conducted according to the protocol from the local public health authorities. Again, this is changing time to time, so everyone should be updated like what the guidelines are for your state and for your district. If you take some states, like it may vary from district to district also. So like for example, if you take Tamil Nadu, Chennai follows a different criteria, and other districts follows a different criteria. So you have to consult your district health authorities, and they will be the better people to tell like what triage criteria has to be maintained. So sir has mentioned about the revised ICMR guideline. Like I am not going to go into details about this. So this was published on 18th March. So like there may be question coming regarding there are challenges of pregnant females and patients undergoing emergency procedures. Do they have to be tested? So, like no emergency procedure, including delivery, should be delayed for lack of test. However, sample guidelines are there simultaneously, and because results are not there, deliveries or any emergency procedure need not be delayed. But all the time, like unless otherwise proved, like everybody should be considered as infectious, and standard precautions has to be followed at all the time. And regarding asymptomatic individuals, so direct and high risk contacts of confirmed cases to be tested between 5th and 10th day. Sir has mentioned like why these dates are because of the incubation period and like infectivity period, like up to 10 days, like they can be still be infective. So all those things you can follow based on the ICMR guidelines. So this is a sample triage system of a patient. Like when anybody comes to the health facility, first, you will identify the signs and symptoms of respiratory infection, whether they have fever more than like 38 degrees centigrade, or at least one symptom like cough or shortness of breath or like anything. So if any of the symptoms are there, immediately they will be asked to be a place for them to wait till they are examined. If they don't have any symptom, again instruct them to maintain a physical distancing and send them to a different room, like not where the symptomatics are held. So you can send to a different room, and there they can be waited and they can be examined further. So again, like many patients we have asymptomatic, so still there may be a chance of them coughing or sneezing and spreading the infection, even though the chances of asymptomatic patients spreading the infections as per the current evidences are like might be less, but it is still unclear. So it's always better that even if they are asymptomatic, they should maintain physical distancing, wear mask, and follow all the cough etiquettes whenever they are waiting for like further medical evaluation. So this is the like sample triage criteria. And when you have a patient like who is a suspect, immediately isolate these cases through triage process, and they must be separated from other patients. So this is a example, like this is the All India Institute of Medical Science Trauma Center COVID like hospital, like ICU. So you can see here triage facility like open and well, they are maintained at least 1 meter distance, and cleaning is going on. Like so, it has to be cleaned and maintained properly, because the droplets can stay on the floor, and still like if some accidental touching or something happens and there is a breach in PPE or something, like you can get like someone can get infected. So that's why like cleaning is very, very important in the isolation facilities. So the other inpatient care strategies for COVID, this might change happen in that particular locality, and every time you may have to revisit your admission plan based on the case surge at the particular place. So initially the cases may be admitted in a single isolation rooms because the cases will be minimal. So when the cases surge, like then you may have to consider cohorting the isolate rooms and wards. So then still when more cases consider, like you may have to convert the whole unit of a hospital. Like this is, I'm talking about a non-COVID health facility, like when there is more and more cases and when COVID hospitals are full. So you may have to adapt different strategies for other health facilities. When still more cases come, the whole floor may be converted, and at last, like when there is more and more cases in that particular locality and you don't have beds, so then we have to think about designated unit for the non-COVID patients, because like hospitals might be full with the COVID cases. So like it will again depend on how many cases are like there in that particular locality, and how the hospitals are occupied in that particular locality. So this may vary from place to place. So what the point here is, whenever there is like you may have to revisit your strategy when there is increase in number of cases, and you may have to adapt different strategy when they have more and more cases. And when everything goes beyond your thing, then you may have to safeguard some place for the non-essential, non-COVID cases for essential medical services. So coming to the emergency department care strategies, the ED, usually all the emergency departments work above capacity in India most of the time. In addition to above strategies for outpatient care, ED should consider diversion of non-critical COVID suspect cases at a triage point prior to the ED parking, like maybe in a parking lot or something like that. So they should use specific space like for daycare surgery, which is used for daycare surgery for COVID patients, subject to appropriate isolation of that area from air handling and patient movement standpoints. So they should use discharge waiting areas like which are not routinely used. Like if there are some areas where the discharge patients are waiting, they can use this discharge waiting areas for segregating the patients. So also they can change the patient flow based on the IPC measures they may have to implement. Also, already most of the states are they are having good system of this telemedicine and telephonic triage. So non-critical cases, they can be handled through telemedicine facilities following the Medical Council of India guidelines, so that emergency department visits can be limited to the health facility. So coming to the critical care area IPC, so as always, in any health facility, the patient should be wearing masks to reduce droplet generation, unless they are wearing an oxygen mask. Like all the patients should be wearing medical mask inside the health facility at all times. Intermittent rather than continuous oximetry and cardiac monitoring may be instituted with separate for each patient. So this will prevent unnecessary movement of the healthcare staff attending the patients, and again this will prevent unnecessary contacts with the patients. If you are using inhalers, so that is better rather than using a nebulized medication in the critical care, because when you use nebulized medication, what happens is that has the potential to transmit the, if at all they are having the virus, they can transmit the virus to others. So nebulization has to be minimized, and there should be a good coordination between critical care physicians regarding threshold of intubation and use of bridging techniques. So if you are going to perform intubation or something, the other healthcare staff should be informed, because intubation runs the risk of generating a lot of aerosols. So all the other staffs also in that particular area should be wearing important, because these aerosols can float, and they can inhale and get the infection, or it can fall on their eye, and through conjunctive also the healthcare workers can get infected. So the critical care physicians should assess the situation, and they should recommend for appropriate PPE in the critical care units. So there were questions discussed about the how long the person remain infectious and shed virus after the infection. So at this time, the data are limited regarding how long persons shed infectious virus after infection. But sir has already shown, but again I am telling showing you this. So this is a model from this is from the CDC website, that this demonstrates declining viral burden in upper respiratory specimens as illness progresses and decreasing capacity to isolate replication. So when the disease progresses, the antibody level rises. Sir has shown very beautiful picture of that graph. So when antibody level rises, the replication capacity of the virus also decreases. So by 8th or 9th day, so in the study which was done in US patients, they have found out that this virus, even the virus was able, the virus is no more infective after 10th day in most of the cases. Again, this is just evolving evidence, but as of the current evidence says that beyond 10 days, the person may be, even if you are able to isolate virus from nasopharyngeal swab or from a stool or something, the PCR can detect, because PCR detects the viral particle, but you won't, the virus won't be infective because the virus doesn't replicate. So replicating capacity declines over time. So you can see in this picture that the probability of isolation falls 50% at day 4 after illness of onset, 20% at day 8, and after 9 probably approaches 0. So this is the viral isolation also falls, and even though if you are able to isolate the virus beyond 10 days, it won't be in a position to replicate itself and infect others. So like again, we have to be very cautious because this is evolving evidence, and as per the current evidence, beyond 10 days, one person is unlikely to declines. So there are additional IPC consideration which has to be managed. So I'm not going into detail. You all know about appropriate hand hygiene, respiratory hygiene, and rational and correct use of PPEs, and environmental cleaning. Like this is very, very important. And you have to consider transmission-based precautions for COVID-19 in all the healthcare facilities. So you should use adequate ventilated single rooms, or you can use well-ventilated wards. Wear PPE appropriate for contact and droplet precautions. Use disposable or dedicated patient care equipments, like stethoscope can be dedicated for each patient, or blood pressure cuffs can be dedicated for each patient, so that you don't just transmit the infection from one person to other and unnecessarily carry, carrying will be more riskier. Avoid transporting COVID patients for out of room unnecessarily medically necessary. So because so when you are transporting for CT scan or like something, so it's fine, but you have to plan accordingly. You have to inform the room, quickly transport the patients through a separate way and bring him back as soon as possible, so that he doesn't stand a potential threat for infecting other patients who are non-COVID if you are not a dedicated COVID hospital. And limit number of healthcare workers, family members, and visitors in contact with the suspected or confirmed cases. This is very, very important. Like not only the visitors has to be limited, but also the healthcare providers. So they have to be, you may have cohort the healthcare providers into groups, and like only a particular healthcare provider who's very much in need of care of the patient, so they can be assigned to the particular ward, and not other healthcare providers are not advised to enter, because again, by doing this, anyone who's caring for a COVID patient, you all know they should be wearing full PPE with all the protective gears and goggles and gowns and everything. You can also minimize the use of PPE by doing that, and also you can save your health workforce for maintaining the routine essential services of non-COVID cases also. So again, there may be a lot of questions like what PPE should be used for managing the COVID cases. So the PPE should be decided based on the transmission-based precaution. So there are very clear guidelines from Government of India about use of PPE, rational use of PPE for what procedure or what area, what PPE should be used. So the healthcare workers, the common thing is the healthcare workers who are involved in direct care of COVID-19 patients, they should wear gloves, medical mask, eye protection, gown, and this is the must. Because if you have N95, you can wear, otherwise face shield and a mask can be worn if you are giving the direct, if you are having a direct care of patients. So in case if you are involved in a place where isolation room, where you suspect there may be a aerosol generating procedure conducted, so then your standard of PPE should be gloves and a particulate respirator. So particulate respirator should be not less than N95 mask. So you can use, there are other criteria for classification of N95 masks from the European standards. That is, it should be either N95, which as per the US standards, and also there are Indian standards from DRDO and BIS and ISI. So you have to follow appropriate guidelines issued by Government of India. So if you are using N95, so you please ensure that you are using it has the correct standardization methods and all those things, or you can use a FFP2, which is a European standard, or a FFP3 mask. So along with the mask, you should also use an eye protection. So either it can be a goggle or a face shield, because it provides an additional protection from you. If at all the patient coughs or something when you are doing a procedure, so it won't be directly splashing on your face, and you may get infected. So always wear eye protection also when you are providing care for the patient. So most of the places they are implementing, but so you should encourage, if it is not there, like again, like there is a high risk of getting the disease to the healthcare worker. So you have to be very strict about appropriate isolation areas. So the key point for PP use is mainly you should use correctly and consistently based on the transmission risk, and appropriate training should be provided to the healthcare workers in advance, and mainly they should be thought about correct donning and doffing procedures for different types of PPEs, because now there are different types of PPEs available. Some places they have this hazmat suits type PPE, some are having coveralls and all. So based on that, like the sequence and things may slightly vary. So whatever PPE they are using based on the manufacturer's instructions, you have to train them like in what sequence they should wear and in what sequence you should like doff the PPE. So this is very important, because most of the time PPE removal may be a potential threat for getting the infection. So this people should be trained adequately so that they remove the PPE correctly, so that they don't contaminate themselves. And while donning and doffing, like at each step, you might be aware that you should be doing hand hygiene for each step of your donning and doffing procedures. Hand hygiene has to be done like compulsorily. And like there are some guidelines here from WHO which shows like for a standard PPE, like how you should wear and you should doff. And also there are videos available in the AIMS website and from the Ministry of Health and Family Welfare website and CDC, how to don and doff. But again, so based on your type of PPE, what you are wearing, the gown or coverall or hazmat suit, the sequence may slightly vary. Please see the manufacturer's instructions and follow appropriate sequence for donning and doffing for personal protective equipments. So coming to the important part, this environmental cleaning and disinfection, there are a lot of questions which arise, like whether we should use any specific disinfectant for this COVID areas or something like that. So Government of India has provided disinfecting guidelines for health facilities. So routine cleaning and disinfection procedures are sufficient for COVID. So focus cleaning on frequently touched and frequently contaminated surfaces. So you can, the frequently high touch surfaces are like light switches, bed rails, door handles, sinks, bathrooms and all. So, and hospital grade disinfectants, what you are using is effective against this virus. And like whatever product you use for any envelope virus can be used for this COVID also. So this picture shows you like which all are the high touched surfaces, like bed rails and the handle of the drawer, then the lamp which is above the patient. So all these areas has to be cleaned thoroughly. So if you ask like how frequently floor cleaning has to be, floor cleaning and disinfection, twice a day preferable. And like high touch surfaces, like you have to wash it like with appropriate disinfectant. And this is very important, because like high touch surfaces are the place where someone can touch and they can acquire the infection and transmit infection to others. Like this is for also for healthcare workers and also for the patients or like other patients or visitors, those who are there. So coming to see these patients. So this has to be followed, and high touch surface cleaning is a must. Like this is for COVID area and non-COVID area. This is a must for all the people. And there are some slides, like I have additional slides, but I'll just rush through because we have very less time. So here are some calculators which has been developed by WHO. There is a calculator from WHO and there is a calculator from CDC, which can be used for calculating your PPE burn rate or like your hospital equipment's burn rate. So for during the COVID situation, so you can use this if you want to know like how long your PPEs will exist, whether you have to plan for purchase or not, whether if the purchase is delayed, should you plan for a reuse of some of the PPEs which can be reused? So all those things can be decided based on this. So these calculators can be used for that. So again, managing PPE shortages. So currently, like most of the hospitals doesn't have this problem, I believe. Like there are adequate PPEs in most of the health facilities. So disposable PPEs are generally intended for single use and only, and should not be reused unless there are no other options exist. So if there are, like if you have adequate number of N95 respirators, you should not be thinking about reuse. But if you don't have some of the PPEs, then you can follow the national guidelines. There are guidelines from All India Institute of Medical Science regarding reuse of some of the PPEs, how you can disinfect them and use, and when you can use and when you should not use. Like these guidelines are available. So when you have limited supplies, like you can consider reuse of PPEs and extended use of PPEs also. But again, when you have adequate use, a number of PPEs available with your institution, so this should not be considered. This is the last resort when you don't have adequate like PPEs in your health facility. And like these are some pictures where some health facilities, they prepare their own like shields and all. It's a low cost affairs because the supplies were delayed and they started preparing their own face shields. So this is indigenously they have prepared. Consider this option also. And so these are some slides which can show, which shows about like whether soap and alcohol based, like are they equally effective? Yes. Soap also disintegrates the viral envelope because viral envelope contains lipid based membrane. So it easily disintegrates, and soap is equally effective as alcohol based hand rub. So you can use soap and water also if alcohol hand rubs are not available. And this picture shows about like there is a WHO guideline which mentions about like if you don't have alcoholic hand rub supplies, how to prepare it in a health facility by using this WHO protocol, by using isopropyl or ethyl alcohol. So there are links, you can follow this here. And here I would like to share some resource materials which can be used, some trainings and resource materials which are from the Ministry of Health and Family Welfare, WHO and CDC. So you can use these training materials. There is a IPC course, you might be aware, from OpenWho, and also there is a IPC course from CDC, and you can use this courses. Like you can do these courses and get more knowledgeable on infection prevention control measures as to be for implementing in your health facility. And that's all from me. And I would like to acknowledge all the COVID barriers and frontline public health like TOT workshop, which we all gained basic knowledge about all the COVID things. Dr. Purva Mathur from AIMS, Dr. Mala Chabra, Dr. Shivlal, Dr. Anil Kumar, Dr. Jugal Kishore, Dr. Rupali, and Centers for Disease Control for giving me this opportunity to present. Thank you all. If you have any questions, we can discuss at the last.
Thank you, Dr. Valan. Thank you for a nice presentation, and thank you, Professor Jugal Kishore, who has initially given very comprehensive talk, and he has shared everything, starting from the current evidences, knowledge, research, and also about the response, Government of India response, and then supplemented by Dr. Valan regarding the infection prevention control strategy at the healthcare associated infection and their prevention. So my talk is almost some of the content had been covered by Professor Jugal Kishore. So I will not go into the detail, but will give brief overview of this talk, that how and why international and national framework for COVID-19 management is required. Outline is introduction and rationale, and then international framework, followed by national framework for COVID-19 management and acknowledgement. So, we all are living in a global village. Without effective human intervention, epidemics and pandemics typically, and only when the pathogens has infected every available host, like we all are here, and all have either died or become immune to the disease. This is the only, without the intervention. And the present pandemic have taught us that an outbreak like SARS-CoV-2 in one country can how easily and rapidly spread to another country. We all are responsible for stopping outbreak before they become epidemic or pandemic. The IHR international health regulation, are a framework designed to better protect the world from health threats spreading out of control. And World Health Organization, since it has declared as a, pandemic today, while facing global pandemic, the importance of health has been felt by, not by the one country, but it's a global, necessity. The coronavirus has brought life to a standstill, thereby preventing initiatives have been directed towards protecting the frontiers against this invasion. And we always say health threat in one part of the world can health be another part of the world. So we all are at risk. The international health regulation require each country to be able to stop outbreak of any kind or any nature that have to be, if that is spreading internationally, that has to be contained. You see, this is the global aviation network. This is an aerial view of, global air traffic. This is before the pandemic, because during the pandemic, all the international travel has been completely halted. This is an aerial view, how many flights in each point of time connecting one place to another place. If anything happen in one country within 36 hours of time, that can be travel or transmitted to another country. So we all are at risk. What are the international framework? United Nations Health Agency. What is the United Nations Health Agency? United Nations has created WHO, World Health Organization, in 1948 with initial 165 member countries, and the primary responsibility, primary objective of this WHO creation was responsibility for international health matters and public health. Beginning with this International Sanitary Convention in 1892, continuing until today, with this international health regulation have so many changes, so many revisions. And the IHR revised 2005, which is used by the countries to prevent, control public health threats, while avoiding unnecessary interference with the international travel and trade. Well, we have seen, a lot of paradigm shift from 1969 to 2005. Under IHR 1969, only 3 diseases were notifiable, like cholera, plague, and yellow fever. And in 2005, why this has been revised? Because in 2003, when SARS, pandemic started again from China, and that was a big pandemic which has necessitated countries to develop a framework where countries has some responsibility, some accountability, so that become a legal framework, so that every country is, legally bound to report if any events or outbreak happen in that country which poses, threat to the other country. And 2005 IHR established a process for international collaboration and decision making during any public health emergencies. It requires reporting of specific diseases plus any potential public health emergencies, regardless of origin or source. Even that source is not recognized or identified, still every country has to report to WHO. It also established a global network of 24/7 national focal points, and also establish a core capacity for surveillance and response for all, at all level, like local, intermediate, and national level. There are 4 thematic area where WHO is developing the core capacity, like the detect, make sure surveillance system, laboratories can detect potential threat. Under SS, work together with other countries to make decisions in public health emergencies. And under reporting, that report specific diseases plus any potential international public health emergencies through participation in a network of this national focal point, which is available into 24/7. And how to respond to public health threat. IHR 2005 also includes specific measures countries can take at ports, airports, and ground crossing to limit the spread of health risk or threat with the neighboring country and prevent unwarranted travel and trade restriction. That's why we have seen in past, various travel advisories issued by, many countries that stopping international travel. What are international health regulations? International health regulations, legal instrument that is binding on 196 member countries across the globe, including all member states of the World Health Organization. And it intend to help prevent the spread of disease across border and outline the minimum requirement for functional public health system that allows country to quickly detect and respond to disease outbreaks in their community or at their local level. Since 2005, when this was revised and put into the place, that there are, various changes happen, and which IHR entered into force into June 2007. And this rapid identification allowed WHO to quickly guide and coordinate with global response to such an event, which minimize unnecessary interference on travel and trade. What are the potential public health? Sorry, I'm just shifting this. Yeah. What are the potential public health emergency of international concern? There are 4 diseases always need to be reported to WHO. Like earlier, only 3 diseases. Now under 2005 revised IHR, there are 4 diseases always reported to WHO: severe acute respiratory syndrome, SARS, smallpox, new influenza virus, any new strain, or wild type of polio. And WHO determines if that event poses threat to the other countries, and then declare public health emergency of international concern. There is also emergency committee which reviews and assess and reviews the event, and then recommend to WHO DG to declare whether that event has PHAC potential or not. The role of countries is to assess the magnitude and potential risk involved with that with an event, and WHO role is to make the decision. With this design, WHO as our global public health authority can assess and global risk of an event, and if needed convene countries and mount a coordinated international response. Countries do not need to know that what is the cause and what are the source of that threat. So they have to report to WHO. The focus is on early detection and reporting to allow that public health response before international spread occurs, at least minimize the global impact of an outbreak. And we have seen the impact, currently what we are facing. An example of present event, that COVID-19, whether the event meet 2 assessment criteria or not. So that will go into the detail. Sorry, I missed this slide. So there are 4 decision criteria used to assess any public health event. Whether this event has public health impact with this event potentially serious or not, whether this event is unusual or unexpected, whether is there any potential of international spread or potential for travel and trade restriction. If any of 2 of 4 criteria are met, then countries are required to notify WHO within 24 hours. And also there is a decision matrix that if any event is identified within 48 hours of identification, country has to assess the situational awareness, and they need to assess and the risk assessment done within 48 hours. And if it requires, if it puts into 2 out of 4 criteria, then it has to be reported to WHO. And 4 diseases are always reported to WHO, which I have earlier mentioned. And an example of present event that COVID-19, whether it matches with the PHIC criteria or not. Yes, it matches because SARS is always under reporting, and if that event is identified. Now coming back on the country legal framework. So India, has an excessively fragmented landscape for health policy, and Dr. Valan has also mentioned about something about that, and Professor Jugal Kishore has elaborated on acts, policies, legislation. The Epidemic Disease Act is one of the element of multiple intervention in public health, in India. The limited purpose of this law allows states and take extraordinary measures at the time of that, this dangerous epidemic disease. And the national framework under Constitution, public health and sanitation are the responsibility of state and local government, while union government manages port quarantine, interstate migration, and quarantine like international health. 8 state and union territories have legislation for public health, and union government measures to prepare and respond to COVID-19 pandemic. This is the sequence and chronological of the event, COVID-19 management. January, union government invoked power under Disaster Management Act 2005 to enhance the preparedness and containment of COVID-19 and hospitals, and also notified the pandemic as a disaster, enable that the state can use funds from state disaster response funds on COVID-19. Also in March, Ministry of Health and Family Welfare advised state to invoke the provision of Section 2 of the Epidemic Disease Act 1897. And as a signatory to IHR, International Health Regulation, India need to establish an appropriate public health response to international spread of diseases. So how to, contain, how to stop the spread of this disease. So India has already the capacity integrated disease surveillance program, IDSP, under NCDC. And what is Epidemic Disease Act 1897? What are Disaster Management Act 2005? We'll go little brief detail about that. This law is we always call a colonial law. Before independence, you might be knowing that Bombay and how the Bombay plague of 1896 played out. The Bombay plague, bubonic plague epidemic was a big epidemic, and that struck the city of Bombay. And it was in late 19th century, and that plague epidemic killed thousands, and also thousands of people fled from that city, and that was a drastic fall in population of that city. And British, government, that time they have developed an act, and they have developed this law in 1897, how to, stop the movement of the people from one place to other place, how to quarantine, how to isolate. So those measures were not there. So because of that necessity, British government has developed that act, and that in order to combat such epidemic, the Epidemic Disease Act was enacted in 1897. The Act of 1897 authorizes center and state preventing transmission of hazardous epidemic diseases by various public health measures like, lockdown, non-pharmaceutical intervention like ban general meetings, restrict assembly, congregation, shutdown of the schools, colleges, and also ask offices to close, and like work from home. So these were the measures in which Act provide, and there are various sections under that Act. Section 2, it gives discretionary power to the states. However, this was not with the central government. So this Act was revised in 1920 to give the power to the central government, because this Act was specific to the Bombay region. So then in 1920, this Act was revised, and Section 2A gives power to the central government that any part or even in entire country is threatened with an outbreak or of an epidemic, may take measures and prescribe regulation. This section gives central government the power. And Section 3 of the Act gives power for punishment or penalties. So with this section, government can use under Section 188 of the Indian Penal Code. And The Epidemic Disease Amendment Ordinance 2020 was promulgated on April 2020 because there was, many felt need that there was a big issue of healthcare personnel safety and their security. So this promulgation and this revised amendment provide protection for the healthcare personnel and damage to the property, and also gives power to the central government to regulate the inspection of any conveniences like bus, train, goods vehicles, ship, vessels, aircraft, leaving or arriving at any land, port or airport. Also further, additionally, central government may regulate the detention of any person intending to travel by these means. And also, this revised amendment gives powers to the state government to revise their framework. So many state has also revised their this act and also put legislation for the surveillance officer, IDSP program surveillance officer can go and visit to house or any premises for inspection, quarantine, isolation. So those are the legal powers have been incorporated, and also it gives compensation, like various compensation packages has been included, and also this I talk about the investigation part and trial. Now coming back to the evolution of the Disaster Management Act. Until 2001, responsibility of the disaster management was with Agriculture Ministry, and this responsibility was transferred to Ministry of Home Affairs in 2002. And with this Home Ministry authority, National Disaster Management Act was established. Disaster Act was established with the Executive Order in September 2005, and Disaster Management Act passed in December 2005 in the Parliament. Also, I will talk, give brief about that. This promulgation of Epidemic Disease Act 1897, which has to be ratified by the Parliament. So once we will have the Parliament session, this promulgation will be ratified by the Parliament. Then only it will become a functional act. Disaster Management Act 2005, when this was developed, that disaster management, it provides developing policies, guidelines, frameworks, and so far, it has developed under this act, Disaster Management Policy in 2009, National Disaster Management Plan 2006, and National Disaster Management Plan 2019. This was recently released by Honorable Prime Minister. What is the paradigm shift of disaster, managing disaster from Agriculture Ministry to Home Ministry, then an autonomous institution, like institutional as well as legal framework? A paradigm shift from response and relief centric approach to proactive prevention, mitigation and preparedness driven approach. It lays down institutional and coordination mechanism for effective disaster management at national, state, district, local level. It establishes that, with this act also provides developing the capacity, providing financial resources, providing information. So with this, National Disaster Management Authority was established, and National Institute of Disaster Management was also established, and also to support the state and for the national or state response, a National Disaster Response Force was also established. With this organogram, Honorable Prime Minister is the ex officio chairperson of the National Disaster Management Authority, and it has been also, various changes have been taken place so far since 2005, and it is now created a multi-tiered institutional and coordination system. There is a National Executive Committee which is chaired by Home Secretary. So you have seen all the executive order of the government which is issued by the Home Secretary, and also from the Disaster Management member, that they are quoting this Disaster Management Act 2005 because it provides that it gives the power to use this act. State Disaster Management Authority also established, which is chaired by the chief ministers, and in Union Territory, it is chaired by Lieutenant Governor. And also, this is a decentralized, nomenclature. Like District Disaster Management Authority is headed by District Magistrate and Collector. And it has mandated that every state and union territory and district should prepare a disaster management plan and also stipulate that setting of various funds under these disaster management, and also let out offenses and penalties, which is also now part of Epidemic Disease Act. And it empowered the central government to issue direction to central ministries, department, agencies, and also the states and union territories. So all these guidelines, directions have been issued by central government with this act. State and union territories are also encouraged under this act to set up a state disaster response force. So many states are in works of developing these, forces. This is the institutional framework: National Disasters Management Authority, National Crisis Management Committee, chaired by Cabinet Secretary. So why I put this NDMA? Because NDMA is chaired by Honorable Prime Minister, and National Executive Committee chaired by Home Secretary. Then you have various ministries are part of this, and whenever this subject comes in, if it is flood with the, it goes with the line ministry. So like this is the biological disaster, so that's why Health Ministry is leading this. And it comes under the State Disaster Management Authority and then District Disaster Management Authority. This is the legal and institutional framework. I will not go into the detail. This is like the central government, state government, and district administration. And also this has, link with the panchayati and municipality. So many districts has given authority to, using this power with the chairperson of Jilla Parishad. Like Chhattisgarh government has given that power, same power which district magistrate has. And what are the additional legal framework? Like, this was also mentioned by Professor Jugal, the Aircraft Public Health Rules 1954 that empowered health officer to check citizen arriving from abroad or airport entrance, like, entry screening or exit screening. Code of Criminal Procedure, CRPC 1973, section 270, 188, state specific public acts. Various states has also developed the acts. And other elite Indian legislation like the Livestock Importation Act, Indian Port Acts, Drug and Cosmetic Act. And why I put Drug and Cosmetic Act? Because, section 26B empowers central government to regulate, restrict, or manufacture drugs in the public interest. That's why you have seen that hydroxychloroquine or chloroquine have been banned for exporting from India to other countries. Later that was lifted slightly. So this is Drug and Cosmetic Acts give that power. And state level resolution like Madras Public Health Act. These are various acts, even colonial era act, like the Cochin Public Health Act, Goa Daman and Diu Public Health Act, West Bengal Epidemic Disease COVID-19 Regulation, Maharashtra Regulation for Prevention and Containment of Coronavirus Disease. This has linked with the Integrated Disease Surveillance Program, and Delhi Coronavirus Regulation 2020. So thanks for this. I conclude my talk and presentation, and I acknowledge this is from Dr. Valan has also used this slide from TOT workshop slide presented on March 6th and 7th under Ministry of Health. And thank to Dr. Sibla, Chairman of Indian Association of Epidemiology, Dr. Anil Kumar, President IAE, Dr. Jugal Kishore, Dr. Rupali Dev, and also our CDC office. Thank you. It concludes, and then we can take a question. Dr. Valan, I guess Sweta might have put together all the questions, so we can take one by one. And yeah.
Yeah. So can you please allow me to share my screen?
And again, thanks to ITEC, ITEC has, they are so professional that they have beautifully organized this webinar. And thanks to Sweta and ITEC.
So please allow me to share my screen.
Yeah.
Yeah. Is my screen visible? So is my screen visible? screen visible, sir?
Yeah. Sweta, can you zoom out? Because, yeah.
Yeah. So, first
Can I repeat it,
question
sir?
regarding social distancing, whether, yeah, it's visible, Shweta.
Okay.
So regarding social distancing, whether it should be 6 feet or 1 meter, just like 3 feet or 6 feet, like that is the question. Jugal sir, you want to answer this? Or Dr. Jugal Kishore is there?
Yeah, he's there.
I think he's muted, I think.
Sir, please unmute yourself.
What she has asked?
So whether it is 6 feet or 3 feet, social distancing.
Uh, it is better to have the 6 feet, but
Yeah.
the in case of coughing, it is not going beyond 3 feet
Yes.
because the droplets are quite big in size,
Yes. Yeah.
and in case of sneezing, there are possibility that it can go beyond it. But usually, 3 feet is good enough to control the, you know, uh, that infection.
Yeah, no, if you can maintain 6 feet is better, but like that's why in the presentations it was mentioned at least 1 meter. So
Yeah.
like this, I think answers your question. Like it was at least 1 meter and not 1 meter. So when somebody has a loud cough or like loud sneeze, it can still travel beyond 1 meter and up to 6 feet. So that is the reason it was like you may see like two numbers like 6 feet and 1 meter. So at least 1 meter is a must. And if you can have 6 feet, that is 2 meter distance, like that is well and good. So next question is day of exposure should be classified as day 0 or day 1. I'm not getting the question. Like this is
It is always
day
day
of
zero.
exposure. Day of okay, day 1. Okay. So when you get the exposure, like it should be calculated as day 0. So yeah, so next question is it possible to keep separate stethoscope, BP instruments in country like India? So when in isolation wards and all, like it's always in ICUs also, like it is better to keep separate things wherever it is possible. Otherwise, you have to like disinfect it very frequently, because like after direct contact with the patient, like he might have like sneezed in his sleeves or like something like that. So there may be some viruses which may remain, like sir has already mentioned it, the virus particles may be remaining in the surfaces for some time. So what might happen is there is still a chance of acquiring the virus from the surface when you touch one patient with the same stethoscope without disinfecting. Again, you are using it for other patient, so you can transmit. So if in settings, if you have separate in wards and ICUs, like mainly in ICUs for the critically ill patients, when the patient is more symptomatic, if it is there, then you can limit the transmission.
Yeah, Rekha Anil, actually, she is asked whether it is useful for Indian condition or not. I understand. But the question is that yes, that is the best, but whatever is possible, one has to do according to the availability of the stethoscope and other instrument, which is not possible in a government setting. So the hygiene is important.
Yeah, you have to frequently disinfect. Then for each and every examination, then you may have to disinfect with the alcohol based like wipes or like something like that. You may have to disinfect for each patient if it is not possible.
Yeah, one question was on chloroquine. That is addressed.
No, that is not addressed.
Okay. Dr. Savita has asked about the chloroquine. I think what is the question? That is also not clear. I have sent question of chloroquine use. Uh, that is hydroxychloroquine or chloroquine. The question I can understand whether a general population can use it or not as a prophylaxis. We are already using for the patient who is having COVID uh, in India also, but for prophylaxis, the ICMR has given guidelines only for health workers and not others. Because once you start using in public, then possibility of misuse increases manifold, and there are side effects. Although we don't have very good studies showing the benefit of chloroquine, hydroxychloroquine in prevention of occurrence of COVID or coronavirus. Um, but one study they have shown uh, that this is useful in that is again is a case control study and so
Yeah, we are awaiting results of bigger trials from
yeah,
WHO and also from ICMR. And why public sir is mentioning is, so it will give a false sense of security to the
security.
public. So they don't wear masks, they don't maintain distance, and they don't wash hands. So like the messaging should be very risk communication again coming back to that, unless the right risk communication message is conveyed, public will take it as for granted. If I take this tablet, then I will not get corona, and it's going to be a disaster. So even in the ICMR study, they have very clearly mentioned, like, even if you take hydroxychloroquine, you have to wear appropriate PPE based on the risk you are involved. So then it is more protective. So that's what they have mentioned in the ICMR study also. So so currently the government doesn't recommend HCQS for the public use. I hope
I
this.
think same is applied for other system of medicine because uh, Ayurveda and Unani Siddha and homeopathy, particularly homeopathy and Ayurveda, both are giving. Siddha is also in Tamil Nadu. They are giving as a prophylaxis to everybody. So we don't have trials. They are just they are saying they are immune boosters, so it's good to use it. But we don't have any good trials show that it has the protective effect. So from the uh, scientific point of view, we cannot advocate to the general public to use it, uh, although their ministry is advocating it.
So safety chloroquine, again, like ICMR has very clearly mentioned, a strict pharmacovigilance has to be maintained for, because chloroquine has lot of side effects like retinitis, cardiac toxicities, and things like that. So and it has to be prescribed by a nodal officer from the health facility where you are working. So there are clear guidelines given as an annexure in the ICMR directive to be followed for strict pharmacovigilance, because chloroquine also has this drug also has side effects, and so it has to be very carefully taken. And if you are already having cardiac issues and all, it has to be consumed carefully with appropriate supervision and all. So that guidance has been given by ICMR.
One more question.
Yeah.
Yeah. How entry thermal screening at airports like India would help in containment when disease is already there in the community?
Can you please repeat?
Yeah. How entry thermal screening at airports like India
Okay.
would help in
Okay.
containment when disease is already there in the community?
So you are asking about thermal screening in the airports, right? So the question is how is it going to help? Like, Rajeev, you want to take this up?
Yeah, Dr. Valan, yes, now, as you know, thermal screening is recommended, but like most of the patients now, they are asymptomatic, and sometimes there are very pros and cons. If you have a fever, if you are taking prior to the screening that like paracetamol or
Paracetamol, yeah.
so that happens.
Yes.
Yes, that is not very accurate measurement that you can screen if everyone that high temperature is one of the it is one of the measure
And yeah,
to maintain it.
and also it is one of the measures. There are a lot
Yeah.
of other measures government of India is following. Like you should be from a safe zone in Arogya Setu application.
Yes.
You show that, then only you will be allowed to enter into the airport. This is first. So then you have to provide a self-declaration that last 14 days I didn't have all the symptoms. So like people, I think government trusts in people more about self-declaration. So if you are really a truthful citizen to India, like you have to declare it. Like if you have any symptoms, you have to declare. So there are a lot of other measures and a lot of other screenings other than thermal screening, which will filter if you are whether you are eligible to travel in that particular flight or not.
Yeah.
Yeah, so the next one is related to the previous one. Can measuring oxygen saturation along with temperature be more effective in screening?
Yeah, some hospitals, like I know, like not some, many hospitals in Tamil Nadu are doing this. Like if you are a healthcare provider, before entering into the COVID ward, before wearing PPE, your blood pressure, your pulse, and your oxygen saturation is tested, because what they convey, they have observed that people who are asymptomatic, with no fever, no cough, but their saturation was low, and like later they turned out to be positive. Like some states are doing this as a healthcare worker screening, and even this special officer on duty for Tamil Nadu recently in the public press briefing, he said, so people should also we should adapt a method of screening through pulse oximeter, oxygen saturation, because like symptomatic screening is not not always helpful, because many people are asymptomatic, those who are coming to the health facilities. So it could be. Sir Jugal sir, you have any inputs regarding using a pulse oximeter as a screening tool?
Yeah, it is costly affair, but it's not invasive. Like the thermometer and oxy pulse meter, that is non-invasive, so can be applied. And more criteria you use, although it becomes cumbersome, but the specificity increases of detecting the person. And therefore, if we increase the criteria, definitely it is useful.
Yeah, just supplementing, in one of the meeting with yesterday WHO partners meeting, there was discussion that many of the states, they are now proposing that if home care provider, like if someone is having mild symptom or moderate to mild symptoms at home, also can measure using pulse oximeter at home. So that is also now explorable. That is that possible to use that, because this is non-invasive and anyone can measure it.
Yeah, this is the last question. What is your take on community transmission in India?
Sir will answer this question appropriately.
Yeah. It is a $1 million question.
Dr. Valan should take up.
No, me should take. Okay. So again, there are a lot of confusion. What do you mean by community transmission? Like there starts the problem. Like because the whatever definition made by WHO was like not very specific and things like that. So instead of focusing on community transmission, we should focus more on identifying the hotspots, like clustering of cases, isolating the cases, and providing them appropriate treatment and things like that, rather than the debating about community transmission is there or not. So recently ICM, because the definitions itself are very ambiguous, like the definitions which were given by WHO, it's not very clear. So, and there are a little bit like agreement between some of the countries regarding that particular definition. Like what do you mean by community transmission? So we don't have to enter into too much into that, but our focus should be how we can prevent the transmission, how we can contain, and how we can move on to the mitigation, like the next level for this. And for like, like now we understand like most of the clustering has happened in like high density areas, like in many of the urban cities like Delhi, Maharashtra, Mumbai, Chennai and all. So let us, like, I think government machinery is very hardly working for most of the containment measures, and we should focus on that. And I think there are people who will decide whether what is community transmission and when should declare, like that will happen on appropriate time.
Yes, sir. I think we can take this last question. Is India doing syndromic surveillance?
Syndromic surveillance, that is ILI, so like SARI and ILI surveillance.
Yeah.
Do you mean?
Yeah,
Yes.
one can say it's a syndromic surveillance.
Yes.
Because we are already doing this SARI and ILI.
Yeah. So ILI has been done like even before COVID, like for flu-like illnesses. So already the system is in place. Like Rajeev, you want to comment on that regarding ILI?
No, I will not talk about the highlight, but yes, some of the hotspot government, like state government is, they are doing active syndromic surveillance, like, using ASA and other healthcare workers visiting door to door for, the syndromic surveillance. They have already structured, that recording that. So yes, I think Sir will talk about more on ILI and SARI.
You want me to say, he's asking whether we are doing it or not. In community, yes, at the surveillance is, going on with the contact tracing. So our workers, we have the ASHA worker and health workers, they are going house to house. They, in some state, they are using teachers also, and they are training for one day, and then they are going to house to get the pick up those all SARI and ILI and other even symptomatic. So when it is symptomatic, it becomes a kind of a syndromic approach where we are not classifying whether the person is having, just these are the screening tool, and a screening tool actually should be broad enough to cater, whether this fit into the definition of COVID. So my answer would be yes, we are doing it at the community level.
Yes, sorry for the delayed question. Has there been any assessment of chloroquine or hydroxychloroquine effectiveness in preventing COVID? Because several doctors and police personnel have been infected and even lost life. Were they given chloroquine?
So for effectiveness, like there is a ICMR study of a case control study like that we had already discussed. So that is already there. And like again, chloroquine along with personal protective equipment, if they are used based on the risk, so that will be more beneficial than only with chloroquine. So that's what they have concluded in that paper. Like it was published on 28th of May, it seems like. If I may be wrong with the date, but it was around that, like last week of May, the study came out from ICMR, and ICMR has like revised and reiterated on chloroquine as a prophylaxis therapy. So I'm not sure about whether police personnel are given chloroquine. Maybe like anyone from others can comment whether police personnel. I'm aware of healthcare providers, but not aware of police personnel being given chloroquine, hydroxychloroquine. Sorry.
Yeah, I just want to share my knowledge. In many states, they have given to the administrative officers also, and the people who are working in secretariat. Everybody has got the prophylaxis of chloroquine. So it's all depend on the state to state what policy they have taken. As I've told you, in one state, whole district was given two medicine. One is Ayurvedic medicine, and other is the homeopathy medicine. So both were given house to house, as a prophylaxis. So we don't have a study. It's rightly asked whether people who have died, we should have done the study whether they have taken the, chloroquine or not. So these are all, studies which need to be done, and future will tell, what is the answer. But today we can't answer this.
Coming back to sir, like whole Tamil Nadu state is recommending two medications from Siddha. So one is like which was already given for dengue as a prophylaxis, Nilavembu Kashayam, and another one is Kapasubakudinir, which is a new thing. Like two drugs are recommended by the government and the Ayush Ministry and all. So, but again, we don't have, these are anecdotal reports and we don't have any scientific evidence to prove these are effective. So maybe future will tell.
I think Dr. Valan, we have, extended, already extended our time.
Yeah.
So we'll take last question.
Yes.
I don't know, last question.
So,
Software.
Is any software tool is there by ICMR for contact tracing? For my knowledge, I don't know about any, but already, Arogya Setu app is already there. So that is very efficient. So why to, reinvent other things?
Yes, and some states are specifically, they have developed tools. Like I heard like some areas in Maharashtra and even Karnataka, Kerala, they use some contact tracing tools which will alert through the Google, Google Maps, like Google Maps tracks your location always. So there is something Kerala did for initial contact tracing, some Google Map based tracking tool. But I am not aware of anything other than Arogya Setu. Arogya Setu itself will give very good information where these people went and where they were there. But provided they should have installed and kept Arogya Setu since beginning. That's why government is promoting all the public to use Arogya Setu application.
Yeah.
So I am,
Rajeev,
other than that, some states are doing which I am aware. Yes, sir.
Yeah, Rajeev, you can now wind up.
Yeah. So before concluding, many thanks to Professor Jugal Kishore for taking very comprehensive, giving talk over COVID-19 background management, risk assessment, and supplemented by Dr. Valan on IPC, and I also added some, legal framework on it. And really thank you to, IAE President Dr. Anil Kumar, who has given this opportunity to share our experiences with members of this was specific to IE members, because this platform is a huge platform where all professional FP and public health expert, microbiologists, entomologists, various public health experts are part of this huge platform and organization. So I'm really thankful to ITech for organizing and hosting this. So big thank to Sweta, and it was really a good experience, and we have also learned many things out of this talk. And thank you, Valan, and thank you, sir. Would you like to say anything at the last final comment? Thank you.
I've learned from Valan. He's good presenting, a very good thing. And you have given so many, history of the laws that is required for everybody to learn, because these laws are very important. They give, teeth to the whole thing. So overall, I think very well done, and I'm thankful to organizers and CDC Delhi branch. Thank you very much.
Thank you, sir. Thank you. Thank you. Thank you. Thank you. Thank you, Sweta.
Thank you, sir.
Bye, Sweta.
Bye.
Bye.
Bye, sir.